subject, which is referral management. I think that it's a critical aspect of any practice, whether it be specialist practice or primary care practice. It has multiple layers of goodness to it. One of them is the patient is happy. Happy patients do word of mouth. It is good for building relationships between primary care and specialists. And it is a wonderful marketing tool as well. So we're going to talk today a little bit about this process. We have already put together our referral management output that we talked about. And if you haven't started it or haven't worked on it, this will kind of put this together. And I call this closing the loop. Next slide. And this is just our disclaimer for Medicare that we put this together. Next slide. So what we're going to find out today in this module is the referral process is a bit like the tango. It requires partners to work in coordination to optimize the outcome. It's a back and forth, a give and take. So if it's done correctly, those referrals will provide important and timely recommendations for patient care without the undue burden for clinicians or for patients. So frequently, this referral process creates a lot of frustration and a lot of additional work for both the practitioners and the patients. So if you can get these referrals optimized, this would be the core activity of care coordination, which is all about the stakeholders in the value-based payment environment. It also will reduce burden for you and your staff caused by missed appointments or incomplete patient information. Nothing worse than having a patient show up in your office for a consultation and neither one of you know why they're there. And so this really helps. It helps the frustration for your staff. And it kind of is a trade-off. So you'll say, well, I don't have time to review all this ahead of time. I just don't have the time. However, if you took that time, you would then lose the time that you're spending with your staff running around trying to get referrals, lab tests, trust, anything like that at the time of the appointment, making the patient sit and wait while we get everything. It would all be taken care of at one point. So we're going to talk about some improvements from both a referring doctor and a receiving practitioner. Now, on the call right now today, we just have two specialists. So I'll focus on that unless we have two primary cares that are supposed to be going today. Next slide. So the first thing we're going to talk about is managing these referrals, and this is assessing what your current referral process is. Next slide, please. So when we talk about the change package, we're talking about ensuring quality referrals. We're going to engage members of the medical neighborhood to help us create a high level of service and quality. So the first step you might want to do is get your staff members together and ask them to contribute to the referral process. Ask them, they will tell you what is your source of frustration in the referral process, and the staff will tell you that. Then reach out to one or two of your colleagues that you refer patients to, or that you receive patients from, and tell them that you want to help the patients and the practice, and you want to work with them on figuring out what is the best way to create this referral process. Don't tell them that they're not sending the work and they're not doing this and they're not doing that. Ask them how we can make it better. And this conversation will lead to ideas that you can work together to make sure that the referral process might be optimal, such as maybe when you refer, or when we refer patients, we're going to send this, this, and this. And you may say, well, that's really great, but I need this as well, if you thought you could get that together. Those are the kind of things that we're looking for. Next slide, please. So we completed that assessment a couple of months ago, and the output helps you to go through the process of optimizing that. But you might want to systematically make some changes to the process and document those changes in the operations guide that you were given with the referral management output. And start with the pain points. What's the most annoying part of receiving a referral? That might be the best way to do that. And then involve all the staff in those changes. And those that are involved in the process know where those challenges exist, and they'll give you that information. You could map or outline the redesigned workflow process. If you look down here, there's a link which says, which is in red, that you can click on, and it will give you process mapping. And you all received a copy of this presentation, so you'll be able to click on those links and learn how to do a process map. Next slide, please. So the next thing we're going to talk about a little bit is providing a referral. Now, I know that specialists, I'm sorry, I have a tickle there. I know that specialists sometimes, most of the time, don't do as much referring out as they do receiving. But there is an occasion where a specialist might need to refer a patient somewhere, maybe to Lisa, maybe to an endocrinologist, or Dr. Bondi, maybe you've discovered that the patient has some other issue with their eye that they need addressed by an ophthalmologist, or referring it back to the person that referred to you. Or maybe there's another specialist that might need to see that patient who has thyroid eye disease, and maybe they need to go to an endocrinologist. So the first thing is having a collaborative conversation with the patient to make sure that they really understand the reason for the referral and that they've agreed to the referral. There are often times that patients don't really understand why they need to go to this other specialist, and they don't really want to, but they'll go, and they'll go in and they'll say, you know, I'm here, but I really don't want to be here, and I really don't think I need this. Or there'll be a no-show. So the patient needs to understand exactly what the referral is for and what they need to do, so that they also need to know, are they going to schedule the appointment, or are you going to schedule the appointment? Most practices prefer the patient schedules them so that they can know their times available. But either way, the patient should know this, here's the name and the phone number, and I need you to get that appointment scheduled. Maybe if it's really urgent, you're going to schedule that appointment because you're going to get them squeezed in. There is a process, and it's a technique called teach back. And it's helpful to ensure that patients really understand the importance of the referral. And so there's a link here too to learn the teach back technique, so that maybe you can make sure that the patient is very clear on the reason why, and that they have understood that reason. Next slide, please. Providing a high-value referral request. So it's really important to provide that really high-value referral. So make sure that the clinical question asked of the receiving practitioner, and provide supporting data like prior treatments, related imaging, or the urgency of the referral. There are two links here One is the toolkit for care coordination, which is excellent, and it has lots of data sets. It has for common conditions and things that would be needed. The College of Physicians has a high-value referral request checklist, and it's helpful to get those referral guidelines established so that you know exactly what you need to do. Next slide, please. So let's define the practitioner's role as well. So clarify what you're asking of the receiving practitioner. You might need to evaluate, see if the referral is necessary, or if they are going to perform a procedure, or how you want them to take care of the patient until they're stable. So there's different ways practitioners can work together. So maybe pre-consultation, pre-visit preparation, a medical consultation. So the receiving practitioner evaluates and advises with recommendations for management, and then sends the patient right back to the referring practitioner. Maybe there's a procedure, so the receiving practitioner might confirm that need and also perform the procedure if it's appropriate. Another way is shared co-management. So the referring practitioner and the receiving practitioner would share the care for the referred condition. Referring practitioner lead first call. Next slide, please. You can work together. There's a co-management. I know that there's many years ago, we developed a co-management program in ophthalmology with ophthalmologists and optometrists. And so the optometrist would do the initial consultation for cataracts, and then they would refer them to the ophthalmology practice, who would then do the cataract extraction and the first post-op visit, and then they would send the patient back to the optometrist to do the remainder of the co-management, and then if glasses were needed or whatever was needed, they would go back to their optometrist and have that done, and they worked in conjunction together. There could be that the referring practitioner assumes the management and care while the patient is in some type of crisis, and then once the condition is stable, they go back. Or the receiving practitioner just assumes ongoing care for this condition. And then there's the complete transfer. Say your patient needs a referral to go to someone in another state because they're moving. And so you would do a complete transfer of care from the referring the patient to this other practice. So there's lots of different roles, and you have to consider them when you're trying to make sure that you're optimizing this referral management process. Next slide, please. And this is my favorite, closing that referral loop. So you're going to ensure that the referral you made was completed. So you should either receive a referral note or maybe a notification that the patient didn't show or cancel. A lot of clinics will periodically review open referrals. Sometimes it's in your system, sometimes not. Sometimes you have to do it manually and track down exactly what happened, and calling the receiving practitioner if you need to get that information. This step also involves confirming that the practitioner acknowledged receiving those recommendations and that the patient actually attended that referral appointment. Next slide, please. So now we're going on to receiving that referral. So the components of an efficient referral process. Next slide, please. So it's really important to look at new referrals in a timely manner. So practices should set up a review process to look for pre-consultation requests and evaluate that the question that the reason for the referral is clear, and that you have the supporting data that you need and how urgent the consultation is. Practice should have some type of system to evaluate and accommodate those urgent referrals that you need. Next slide, please. So make sure that appointment is set at the appropriate time with the right practitioner. Make sure that urgent needs are not waiting long, match those care requests with the actual expertise of the practitioner who will see them. You may have a practice that has multiple specialties in their practice or subspecialties. For instance, I use ophthalmology. I was in ophthalmology for a long time. Ophthalmology, they might have a glaucoma subspecialist. They might have an oculoplastics. They might have a retina specialist. They may have a cataract specialist. So you want to make sure that when you refer to that office, they actually got scheduled with the correct provider to make sure that that's taken care of. Next slide, please. And then make sure you can use something called shared decision-making and teach back for that to ensure that there's clarity and understanding, and make sure there's a written summary to the patient that includes any decisions for care and recommendations in some kind of clear language. Those two links, shared decision-making and teach back, are very important. And it would be a good idea if at some point in time in the next few days that you click on those and read some of that material to make sure that you understood this as well. Next slide. So making sure that you're providing that high value referral request to make sure that that you include the important information for patient care. And the response should also include what the receiving practitioner needs to do, what the referring practitioner needs to do, and what the receiving practitioner instructed the patient to do. So the response should also have some kind of ongoing role of the receiving practitioner. So this again is that high value response list that contains all those lovely suggestions. Next slide. Again, we're closing the loop. If the patient doesn't see that, if the referring practitioner or the receiving practitioner does not see the patient, the receiving practitioner should notify the referring practitioner about any no-shows or cancellations. Or if the receiving practitioner referred the patient to another practitioner who could more appropriately answer the clinical question. That way, closing this loop, the referring practitioner is kept in the loop and knows exactly what's happening. I saw this patient for a consultation, but I felt that they needed to go to this person. So I referred them to another practitioner just so that you know where the patient stands. It's just all about communication. And I know it's hard when you're busy, but it's really critical for patient satisfaction and patient compliance. Next slide, please. So we'll look at a couple of the change concepts that come up that were included in this process. Next slide. So before we get here, I just want to make sure that everyone understands that this referral process, this give and take process, is really critical for your patient satisfaction and for you to communicate back and forth between referring practitioner and receiving practitioner, keeping that loop together. For if the referring doctor receives all this information from you, it will be a great marketing tool because all of them will remember your name because they'll say, hey, they really care about their patients and they're sending me information and making sure that I know exactly what's happening with this patient. And in fact, with the referring physician as well, when the referring physician is referring to the specialist, should the specialist need that type of referring physician, that's the person he's going to send it to. Why? Because he has a relationship with that practitioner, a good relationship. So when we look at this change package, it's built on this driver diagram. And this is the changes that are needed for the TCPI goals for this program that we're trying to do. So if you look at this column, so patient and family-centered care, This includes patient and family engagement, those surveys, team-based relationships, just what we were talking about with referral management, population management, those high-risk patients, the practice as a community partner, making sure that you're involved in the community, in your immediate community. With Lisa, Dr. Hugh, she is a dietitian. She has lots of nutritionists, dietitians, all of that, and as a community partner and a great adjunct to other patients. Coordinated care delivery, that's what referral management talks about a lot. And continuous data-driven quality improvement, engaged and committed leadership, leading your practice, making sure your practice is engaged with the patient. Quality improvement in your practice, making sure that you're asking your patient, what can I do to make my practice better? Optimal use of technology, making sure you're using technology to the best of your ability to get that information that you need. And then also sustainable business operations, strategic use of practice revenue, having that budget versus actual, knowing when you're going to have a little bit of extra money that you could put into something in the practice to make it better, making the staff happy at work, making them feel a part of the practice rather than just a small paid employee, making them happy. Happy staff creates happy patients because they can feel it in their office. And efficiency of the operation of your practice, making sure that office is running optimal so the patient isn't sitting there thinking, what in the world are they doing here? Next slide. So we talk about these change concepts, and there are different change concepts in coordinated care delivery. And one of those steps is ensuring those quality referrals. Next slide. Ensuring those quality referrals. So making sure that you're vetting all your potential referral providers and their agencies. Making sure you're using those personal relationships with referring or receiving providers so that you can cultivate a great referral opportunity between the two practices. Making sure you have some type of inventory of community resources that may be available to your patients that you can send them to, that you trust that they're going to help your patients. Working with agencies, community agencies, to enhance services available to patients. Patient comes in, they don't have any insurance, they might be eligible for Medicaid, they don't know how to go about it. Sending them to the local hospital, to the social worker at the local hospital to get that patient signed up for Medicaid. What a wonderful thing to do for that patient to help them get their Medicaid. Maintain some kind of links to those community-based chronic disease self-management programs or exercise programs or any other wellness resources. I know Dr. Gandhi has a resource online for his thyroid eye patients. Those are great programs, making sure that the patients have access to that and know that it's important to go there. Maybe creating some kind of guide to those available community resources that you can hand out to the patients. And using that philosophy that you should refer to a provider that you would send your loved one to. Next slide. And keeping that list and maintaining that list for some of the medical residents and academic setting, maybe. Engage local health coalitions to identify resources in areas where those resources are really scarce. Find out how patients want quality of care. Ask them, what do you think is quality of care? That's all about those town halls, those patient surveys. Ask them. They'll tell you what they think quality is. It's all about impression, all about perception. And make sure that referral tracking system has a loop closure so that the loop is really flows all the way around. Referring doctor, patient, referral, referring doctor, patient, referral. Next slide, please. And so next slide is resources. I have a quick question. I see someone on here and it says HP owner. Could someone tell me who that is? Who is attending?
That's Dr. Pritchett.
Oh, okay, Dr. Pritchard, welcome. I'm glad you're here.
Okay.
So these are some of the tools that you can click on and get additional information. My favorite is 4 pillars of successful referral management. And now I'd like to go to questions and answers. If anybody has any information that they'd like to share that they do, or if they have any questions about this presentation and what they would like to hear.
Hey, Darlene, I'll share a couple of things about referrals because I feel like this is something that we're really actively working on right now.
Good.
So one thing is a mentor told me a while ago, anytime you see patients or you need to send information back to another referring provider's office is to send a fax with a really nice cover sheet, like an advertisement basically, because you can't go around spamming people by fax. But if you're sending something legitimately, you can also put a little bit of bonus marketing materials in there.
Awesome.
So I've done that and it's been amazing. Like the fax cover sheet, I just make it in Canva and I list all the providers and their credentials and I put a note about we're a network with insurances. Most patients don't have to pay out of pocket. I put a little, once a month, I change the graphic on there. So I'll put like Heart Health Month, Black History Month, National Nutrition Month, Happy New Year, whatever the seasonal thing is or whatever's kind of happening, kind of like in society to make it sort of fun and exciting and eye-catching. And then we get tons of referrals from patients and they come with that fax cover sheet that the doctors hold on to that. And so that happens a lot. And then we were actually like invited to do a program with an OBGYN office. And when I met with the doctor, she was like, it was someone that I knew from before. But when I saw her, she was like, oh, okay. Look at you that you hire these new providers. And the only reason I'm sure she knew about that was the referral sheet because she kind of mentioned specific information that was on there. So I think, yeah, that's been really helpful. And then we're working on automating some of our processes with the referrals. We're not doing every single thing that you mentioned in here. So you gave me some good ideas, but we implemented a patient management system called Keep, which is outside of our EHR. So anytime we get referrals from doctors' offices, sometimes, it takes a little bit of time to get in touch with the patient and schedule them and do all these things. So we put them in Keep. It's to automate it. So the patients will get a message saying your doctor referred you to us. You can schedule online or call us at this number, but it starts to automate some of that process of the onboarding of patients.
That's a great idea.
Yeah. And then we have sort of like a sales pipeline. So we track them. If they don't respond to those text messages and the emails, then we also follow up with them, but it kind of helps
To get the
down some of that.
Yes.
Yeah, but I think one of the areas we're falling short in is we do tend to fax a lot of notes to referring providers or just primary care, or like whoever the primary care is, even if they didn't refer the patient to us. But it is time consuming. It takes, time and money to do that, but we don't have a good process that if somebody doesn't schedule, that we're then in touch with the provider.
Okay. It's good that you're also sending notes to the primary care, even though they might not have been the referring physician, because that's also a marketing tool as well, because you're making sure that the primary care knows what's going on. And that's a really great tool as well.
But I guess I would like to hear from either from you or anybody else on the call if there's a really good strategy or sort of like a sweet spot, because as we try to do all of these things with the referrals, it seems like it's good business wise, but it also is like a big investment of like staff hours. So, I feel like we could be faxing and working on this all day, every day. And where's kind of like the sweet spot financially?
Okay. Let's see, Dr. Gandhi, do you have any idea Athena do that for you? Does it let you know if your patients that you referred out, if your patients are making appointments and those kind of things?
Yeah, absolutely. Yeah, I have some thoughts on that. And actually, I really liked some of the ideas that that Lisa was mentioning as well. It's nice to automate processes because it does, well, it's a double-edged sword, right? Because you mentioned it does decrease staff work on some level, but then sometimes the follow-up aspect of introducing a referral management system requires your staff to focus on like the back end. Like if you have an automated system, just to make sure like that system is working, and that and that that it's working and working for your practice, in terms of like logistics, but then also financially.
Yes.
And years ago, I was in academic medicine at Duke, and we did when we were making decisions about staffing. This is sort of like a side point, but related. When we made decisions about staffing, it was part of the equation was, okay, if we add a technician, for example, how many additional patients can we see in a day or a week? And that was sort of the math or analysis that went into making a financial decision about whether to add a technician or not. And I think they came up with some number, like if we can see one new patient per session, then, which, is time consuming, but if we could, then that would justify bringing on an additional full-time employee, for the year to be dedicated to that specific doctor. So I think you could probably do a similar type of analysis with, like these add-on vendors, because besides the system you mentioned, Keep, there's obviously a variety of other things like that, that are some version of it, where you could probably do an analysis and say, okay, if this program or add-on allows me to see 5 more patients per week, then, maybe that can financially justify my staff working on maintaining, the system, et cetera. We don't have sort of an automated add-on that way, but we receive referrals from sort of like a variety of different sources. So we use Athena, and Athena's pretty good about integrating with other practices. And I'm still trying to figure out exactly how it does that, because I know Athena is widely used in Maryland, but we get notes in our system that just show up from non-Athena users. And it's usually an Epic system, because like we'll get University of Maryland notes and Hopkins notes like in our system for a patient that's one of our patients that's being seen in their system.
Wow.
And so I think that's Darlene, to your question about, what are some of the methods for optimizing referral management? I think sometimes the notes don't even need to be sent back and forth because they just show up in our system. And I still don't know exactly how they do, because I know University of Maryland and Hopkins are using Epic. They're not using Athena, but somehow a lot of these systems are getting integrated now, which I think was the original idea of EHR, but maybe in some ways it's actually happening now. So that was one thing. And then we also get referrals through a system called, well, this is kind of more for our aesthetics patients, but I found it's not always the case, that we might have patients that actually have functional visual problems from drooping lids or something oculoplastic related, where they hop onto this website called Real Self. And Real Self was originally created as a platform for people to seek out aesthetics procedures, but I think it's actually expanded a little beyond that. And I have, so like a practice can have a platform or like almost like a web page on Real Self, and patients use that as a tool for reading reviews, looking at befores and afters, just like almost like a mini website, and then using a link to contact us. Either if they're on their phone, they can hit like a direct call icon, or if they're on their computer, they can just send a note to our office requesting a consultation. And so that's been a useful tool, because we'll get consult requests just about once a week or so through RealSelf. And then of course through our website. So I kind of had our website vendor modify our website a little bit to where there's a tab for patients, and then there's also a tab for providers like referring offices. So our referral form, which unfortunately practices never use, they just sort of like have the patient call us, but we did create a referral form early when we opened that had a listing of like all the different things that I see, because I mean, a lot of people are going to say, okay, well, what's an oculoplastic surgeon? What do you guys actually do in your practice? And it's easier if you can sort of like list everything you potentially do on a, at least general categories on a sheet, and they can go from there for making the referral. So we decided to automate that, where provider can actually hop on our website and go through a tab and put in a referral electronically as well. So that way it also gets through to us right away.
That's a great idea. With Epic, they collect patient, patients, primary care patients, all different physicians that the patient has seen. And it is, if it's working correctly, it will look and see if you have an electronic system that they can fax to. Also, the CRISP program works with that as well. So they will send information through CRISP, from CRISP. If you're signed up with CRISP, it will send you the information on your patient to give you the information. That's how Epic works.
Oh, interesting. So are we receiving Epic notes because I'm signed up with CRISP?
Yes.
Ah. Okay, well, you answered my question. Now I know.
Yes. Okay. Dr. Pritchard, do you have anything you wanted, any questions? Dr. Pritchard is a primary care. So he's on the other end, not a specialist. He's a primary care. Do you have anything that you wanted to contribute, Dr. Pritchard?
Yes, I use Athena, and my referrals go out electronically. The referring office, I'm concerned they're not getting a complete picture of the patient's needs or the complete reason for the referral. For instance, I may refer a patient to a gastroenterologist and the code on the referral may indicate diverticulitis. The referring office, I don't know if they consult with their specialist or not, but they will give an appointment a month from now when the patient is also bleeding. And it requires a phone call from me to that office to be sure that the patient is seen immediately.
Mm-hmm.
The referral form used by Athena probably does, or maybe it does, offer these additional diagnoses and additional complications of the reason for the referral. I'll have to investigate that, but I think that probably they are not getting a complete picture of the patient's needs or the urgency for the referral.
Dr. Gandhi, do you know if those electronic referrals have a box that indicates urgent, or can Athena add that box? Do you know? Because I know you've been using Athena. Dr. Pritchard has just recently gone on Athena.
That's a good question. So can you hear me?
Yes.
Okay. So, you know, I'm sure like his volume's probably going to be higher than mine, and it would be hard to kind of manage it from a phone call perspective. But usually what happens for us is if it's an urgent referral, we'll get a phone call, or now I'm sort of like tied in with, you know, a lot of docs, like we have each other's cell phone numbers, and you have to be careful, like you can't text patient health information, you know, through regular text, but just to say, okay, I have an urgent patient I need to talk to you about, and we get on the phone and talk, you know. So usually we do it through phone calls. Most of the time, to answer your question, what I've seen through Athena is more routine referrals, like, okay, patient has ptosis or something that, if I see them next week versus next month, it's not gonna, affect the patient's eventual outcome. So I don't, I haven't seen urgent referrals come through Athena as being flagged urgent. It's usually like a phone call followed by, now we'll send you our notes if it's urgent.
Okay. So Dr. Pritchard, my suggestion is that you call your rep, your Athena rep, and ask them about, is there some way that we can send those referrals with a box checked or some kind of indicator that this is an urgent referral? And that way but also maybe the phone call is really important if it's urgent as well, to solidify that patient gets seen in a timely manner.
Okay, I'll do that because clearly, everyone is busy, and the referring office that receives a referral almost instantaneously are left to decide the
Whether
urgency of the referral, and maybe sometimes it's just not practical for them to interrupt their physicians to assess the urgency of the referral.
I think
So,
the vendor may be able to put something on that referral that indicates this is an urgent appointment.
and the
Actually,
other-
Trish might know. I wonder, Trish, do you know if we have received any urgent referrals or anything on Athena that was flagged that way?
Trish, you're on mute.
I haven't received anything urgent, but when you're in Athena, when you're signing them, putting the patient's information in, you also are you have to click on that you are willing to accept informations from other places. So I'm clicking that. That's why we're getting a lot of the information from the other practices too.
Okay, good.
Gotcha.
But I haven't received anything showing that it's urgent.
Okay. So that's something, Dr. Pritchard, you're gonna have to ask the rep about.
okay, I'll do that.
Okay.
I have a separate question about referrals, if we have a minute.
Sure.
So one of the challenges that I've come across as a specialist referring to other specialists is sometimes it's hard to locate like who they are or where they are. And it's usually going to be something niche. I mean, obviously Google is a powerful search engine, but there are times where I see patients with drooping lids that I think that they may have myasthenia gravis or some other type of neuromuscular issue. This is just an example. And so finding a neurologist that is specialized or familiar with managing those conditions, particularly through advanced testing like EMG testing, et cetera, it seems to be a bit of a challenge to find somebody in the Baltimore area. And usually I've reached out to my colleagues that have had longer standing established practices or with university practices and say, okay, who do you refer to for, this particular issue, and just trying to leverage my existing contacts. And sometimes I'll get the name of a doctor who, used to do that testing, but stopped doing it like years ago. So it's like not even current information or something like that. Now, I finally just found a doctor at the University of Maryland that does EMG testing, but I don't know why it took this long for me to locate somebody that could reliably, perform a specific function or do a specific type of test, especially in the Baltimore area with the healthcare resources that we have. So I don't know if there is another more efficient way of tackling those types of queries or issues besides just trying to like search around for the right person,
Yeah,
especially when they're niche like that.
I don't know, but I will see if I can find something out. I'll make a note of it and I'll see what I can find out and I'll send it to everybody. Okay,
Thank you.
well, if we don't have any other questions, we have to do the attestation. If you go to the chat box, It's right there in the chat box. You can click on it and you're going to attest to training module number 5. And as soon as you get the thank you screen, you can jump off the call. I thank you all for attending this morning so very early, but it's great to get it done before patients start. This is my absolute favorite subject. So I hope you all have a great weekend, and thank you for doing the attestation for me.